Right, good morning everybody. At JJ&J would just like to welcome you to our first journal club of the year. And let's hope it's going to be a good year. It started off as a hot year, but let's see how we go. I chose two articles from the most recent Annals of Thoracic Surgery, which is the Journal of the Society of Thoracic Surgeons, of which we are all members. It's more the working surgeon's journal and provides sort of clinically relevant practice guidelines. Oh, what happened there? Hey, what happened here? Okay. We had the slide. Okay, it was there. Okay, here we go. All right. And the title of this particular article is Endoscopic versus Open Vein Harvest in drug-eluting stents for bypass surgery left main disease trial. And it's got a very august authorship, including the top interventional cardiologists in the world, as well as some of the top surgeons around the world. And coming from all those institutions, I won't read them all out, but the Excel study was a randomized trial where they looked at stenting with drug-eluting stents for left main stem versus surgery. Important caveat is it was patients with a syntax score of less than 32, which is low complexity of the coronary disease. And it was an attempt to see which had better outcomes. And the outcomes have been a little bit controversial. But the thrust of this particular paper was to look at vein harvesting technique. There's been a big push for less invasive options in harvesting saphenous veins from the leg. And of course, its marketing appeal is less scar. And of course, patients like having a smaller scar because they look good on the beach. But the reality for the surgeon and for the patients is what is actually a better option. The failure rate of saphenous vein at 10 years is approximately 60% in the modern era with using statins and dispirin. And it's multifactorial, and it's always got to do with the vein itself not having an internal elastic lamina, which arteries have. And the intracellular junction permeability on veins is greater than on arteries. And of course, the high pressure of a vein in the arterial circulation. And that's probably what leads to an inexorable loss in graft function. But what is important is harvesting technique, and this hasn't been examined really. The first study comparing open vein harvest, which is the nice big scar that I like very much, and the first study, 2013, showed no difference at 2.6 years in terms of graft patency. In 2014, Hess came out with a study and showed a significant increase in saphenous vein graft failure in patients at 18 months. Andreas showed increased graft failure at 6.3 years in endoscopically harvested vein versus open vein. And the last study by Zanatti showed no difference, but there are multiple limitations in that study because it did not include angiographic graft patency assessment. And also it didn't include target vessel, which is very, very important. So with that background, this is sort of the patient characteristics. There was about 660 patients left from the 900 patients that were randomized. And on the left is the endoscopic vein harvest column. This is the patient characteristics. On the right is open vein harvesting. The only statistically significant differences were race. There were more black patients in the open vein, but it's a very small number, so probably not significant. Body mass index was relevant, slightly more fat people in the endoscopic technique, as well as patients with prior PCI were higher in the endoscopic group, and COPD. But largely comparison, the syntax scores were equivalent. Surgical details, there was slightly more elective patients in the endoscopic group, and more emergency patients in the open vein group. So the suggestion would be that perhaps there were sicker patients in that cohort. In terms of off-pump surgery, more off-pump surgery done in the open vein harvesting versus endoscopic, 32% versus 13%. And that is important when we're looking at the results, because there are limitations in the outcomes of off-pump surgery. So you'd probably expect more problems in the off-pump surgical group. And the number of venous conduits is 1.7 versus 1.5. That's statistically significant, but it's a very small difference. And the operating room time, that's also important, significantly longer in the endoscopic vein groups, and that's because it tends to take longer, and it adds to costs as well. And then the use of ADP antagonists, dual antiplatelet therapy, was much higher in the endoscopic venous group, which makes me wonder if the surgeons weren't worried about the grafts to start with. And ACE inhibitors, I don't think that's relevant in terms of graft patency. This is a look at 5 years where the time to event curves for so-called ischemia-driven revascularization, which could be redo bypass surgery or it could be PCI. And there's a statistically significant difference, 0.047 at 5 years. Endoscopic patients, 11.5%, and open vein, 6.7%, so favoring the good old-fashioned open technique. Postoperative outcomes. This is just a summary of that previous graph showing ischemia-driven revascularization using PCI was much higher in the endoscopic group versus the open group. And there were very few redo bypasses done in that group, so not much difference. Graft stenosis or occlusion, although not statistically significant, is a definite trend towards more graft stenosis and more occlusion in the endoscopic group. MI, stroke, there's no statistically significant difference. So again, this is the time to event curves for graft stenosis or occlusion from 0 to 5 years. So it's kind of a re-looking at the previous statistics, but just looking at stenosis or occlusion, but not all those patients required intervention. So again, that trend towards less problems with open vein harvest versus endoscopic harvest. And this is time to event curves for composite endpoint, that is death from any cause, stroke, and myocardial infarction, was not statistically significant at 5 years. And importantly, a lot of graft failure is silent, but it can be relevant. And this is up to 5 years. And remember, if we follow these patients for longer, vein failure becomes more of an issue. So what were the predictors of ischemia-driven revascularization? When you look at all the different criteria, endoscopic vein versus open vein, and age increments of 10 years. So older patients do worse, and the presence of peripheral vascular disease. All the other predictors were not relevant. So old people, endoscopic versus open, and peripheral vascular disease. And then if we, just going to go. Internet connection is unstable. So I don't know why this slide won't advance. Okay. There we go. This is just the univariate, multivariate predictors of ischemia-driven revascularization, and it's essentially the same. So ultimately, endoscopic vein harvest carries a risk, probably technical and experience related, as well as, there are newer devices on the market, and the companies, of course, will tell you that this is better than the last. It's a bit like stents. The previous stent is not as good as the next stent, because it's all technology driven and it's all money driven. The devices to harvest a vein endoscopically are around 20 to 30,000 rand, and then it adds another 30 minutes to your operation, especially early on. So it is nice for the patient, can have sexy legs, but we need to sort of think carefully about it. And importantly, these patients had syntax scores of less than 32, so the least complex anatomy. And one could probably deduce the more complex anatomy, graft failure is more of an issue, but multiple arterial grafts still remain the gold standard. I don't know, anybody wants to ask any questions now before we move on to the next paper?
So if you have open vein harvest, you'll have ugly legs, but you can go to the beach more times.
Yeah, I think that's about it.
Okay.
Well, you're less likely to have an event. You're not going to die, but you're less likely to have an MI or angina. So, I mean, for old people like me, it's kind of nice. I don't need to try too hard to do endoscopic vein harvesting.
I think the other argument when it came out, because I was part and parcel of that, is the guys argue that the smaller cut with a better recovery and less complications. Sometimes a patient coming with a cardiac failure, the distal limb is more edematous, and when they harvest the upper segment of the saphenous vein, and the argument is, or maybe 3 cuts along the way, and they can get out of the hospital, much quicker instead of the wound infection as such.
Yeah, but in this study, that was irrelevant. And I think most of the vein should be taken from the lower leg anyway, because it's used to higher pressures and thicker walls. So there's no, stay out of the thigh if you can. Yeah. I think that and of course we're doing less and less venous bypasses. So maybe you'll do 3 arterial and 1 venous bypass. So you end up with a relatively short cut in the lower leg. And you saw the number of venous bypasses was 1.7 and 1.5 in this patient cohort. It's a selected group. It's not the be-all and the end-all, but it does add to our knowledge. And it's certainly angiographic patency, which is important.
So for the graft stenosis, how long does it take for us to really see that this is the problem, and what do we do about it?
How long?
How long do you notice that you have a stenosis if you've had a graft? And if that happens less than 5 years, because I heard you say something about the stroke, and what do we do about it?
Well, most graft failures are silent, most of them. Most failures are in the first year and are usually technical. If you have an acute graft failure in the perioperative period, they usually manifest with a myocardial infarction, and then they should go to the cath lab and have an angiogram and see. So out of all those patients, there were a total of 4 patients had redo surgery. Most of them had PCI. But most of the time, graft failure is silent. Most of the time.
James, one more question. The guys also, I think, like any new procedures, they evolve, and then I do believe some of our colleagues in Durban are doing endoscopic radial artery harvesting. Is this part of mention in this paper, or this is just purely talking about the saphenous vein?
No, this is only about saphenous vein.
Okay.
Only about saphenous vein. Okay. Oh, we exhausted this one. Okay. Then we move on to the next paper, and this is more of a, if it'll eventually come up. Okay, this is the Society of Thoracic Surgeons and Society of Cardiovascular Anesthetists and American Society of Extracorporeal Technology Clinical Practice Guidelines for the Prevention of Adult Cardiac Surgery-Associated Acute Kidney Injury. And I think this is a very important paper because it tries to standardize how we look after these patients based on thorough literature review and expert opinion. So all those names again, from Jeremiah Brown to John Haven to, you may recognize most of the names, Rakesh Arora from Houston, and Kevin Lobbell. They're all the people that are involved in the ERAS protocols in the United States, ERAS cardio, and around the world. So what I did is I just started with the executive summary, because I think it's important that everybody understands that it looks after these patients. In adult cardiac surgery with bypass, you've got to avoid hyperthermic perfusion to reduce the risk of cardiac surgery, associated acute kidney injury. Adult cardiac surgery with bypass, goal-directed oxygen delivery strategies recommended, and we'll cover that in a little bit more detail. In adult surgery with cardiopulmonary bypass, it's reasonable to adopt the kidney disease improving global outcomes practice guidelines. Another mnemonic for you to remember, but it's highly relevant, and if we can all stick to the same thing, talk the same language, then we don't have opinions that are people's own opinion. We want to actually be standardized. We all know this now in adult cardiac surgery with bypass. Dopamine infusion during bypass in the perioperative period is not recommended, and there's good reasons for that. In adult cardiac surgery with bypass, mannitol is not recommended to reduce the risk of acute kidney injury. Those of you that are old enough will remember we used to prime the pump with mannitol, and then the patient would go back to the ICU and pass 8 liters of urine in the first 8 hours. And then adult cardiac surgery with bypass, phenoldiprem may be reasonable to reduce the risk of acute kidney injury as long as you avoid hypotension. There's a caveat with that as well, and we'll discuss with that at the end. In adult surgery with bypass, it's reasonable to use minimally invasive extracorporeal circulation techniques to reduce the risk. Again, that's just an expert enthusiast's opinion, and the evidence base does not yet exist for that yet. When we look at, I just got to get my notes here, if you don't mind. There are, for the definitions, and that's the important thing, we all have to be speaking the same language. So these algorithms here that have been generated, and there's this, I've discussed already, kidney disease improving global outcomes, which is the one on the right. The one in the middle, which is the rifle, so it's another mnemonic for you to remember. And that's why I need the notes, because I can't remember. So it's risk, injury, failure, loss, end stage. And then that's what rifle stands for. And then akin, which is another mnemonic for you to remember, the acute kidney injury network criteria. So this committee got together to standardize these criteria. The rifle has no explicit criteria. The akin said if your creatinine goes up 0.3 milligrams per deciliter, which in micromoles is just around 30, or is 1.5 times the baseline within 48 hours. So when these patients go back to the ICU and you check the creatinine in the afternoon or the morning, and the next day you've got to see by how much has the creatinine gone up. KDIGO is the same, and also to look at urine output. If your urine output falls to less than 0.5 mils per kilo per hour. Then they have staging, stage 1, 2, and 3, and they're all pretty much the same. Obviously, stage 1 injury is not uncommonly seen, particularly in the elderly. Stage 2, we'll get the occasional patient whose creatinine will go up to twice normal, and the urine output will fall to less than 0.5 mil per kilo per hour for 12 hours. Then stage 3 is where it goes up 3 times. So when you get our patient's creatinine going over 300. And then the clinical outcomes, Rifle talks about renal replacement therapy for more than 4 weeks, or end-stage renal disease defined as renal replacement therapy for more than 3 months. So what are the recommendations to prevent acute kidney injury and initiation of dialysis by phase of care? The intraoperative recommendations are for patients who are undergoing surgery with cardiopulmonary bypass, avoid hypothermic perfusion. So it's really important we warm the patients to 36 degrees and no warmer, and the blood inflow temperature should not be higher than 37 degrees. And that's important for the perfusionist. Avoid nadir DO2, in other words, the lowest point of your oxygen delivery should not be less than 270 mils per minute per meter squared. I think everybody knows I am a bit anal about adequate values and not just vague numbers. And there's a good reason for it, because the rest of the world likes it like that. Consider minimally invasive extracorporeal circulation and consider phenoldiprem. I don't even know if it's available in South Africa. Don't use dopamine and don't use mannitol. Postoperative recommendations: high acute kidney injury patients. They're looking at elevations in the various peptides, and I'm not sure how many of these we can measure. The practice guidelines can be effective, so close hemodynamic monitoring, and we'll get to that, what that means. Avoidance of nephrotoxic substances such as aminoglycosides, and be careful with vancomycin. Hold your ACE inhibitors or angiotensin receptor blockers for 48 hours. Serial creatinine and urine output monitoring, and prevent hyperglycemia, and that's very important. The next slide will eventually come up as it comes up. Yeah. So standard of care and kidney disease, improving global outcome, bundle interventions. And this is the big, with infection we talk about bundle interventions, and we should be having a bundle intervention for kidney patients or suspected kidney patients. So we look at the elderly, people who have a creatinine clearance that is less than normal for their body mass and sex. So the standard care is to discontinue nephrotoxic substances. As far as ARBs and ACEs are concerned, discontinue for the first 2 days after surgery, but we'll get to the ERAS guideline when they should be discontinued for the 2 days prior to surgery. Keep your mean arterial pressure more than 65. This is not in theatre, this is after theatre. And I'll write this down on the chart. There's a reason I write that number on the chart, because we don't want to lose the kidneys. And you monitor the creatinine urine output. And why do we measure the CVP? Because the general intensivists don't think it's important. Unfortunately for you, that's not evidence-based in cardiac surgery. You've got to measure your central venous pressure because it's a surrogate for right heart. We don't use pulmonary artery catheters. You should be measuring pulmonary artery diastolics if you really want to get down to it. And you should be measuring cardiac indices. So a CVP of between 8 and 10. Avoid hyperglycemia. Consider alternatives to radiocontrast and hemodynamic monitoring and optimization according to a hemodynamic algorithm. That's why we want to do that stuff. So I think all of that is self-explanatory. The paper is quite comprehensive, but it's not over the top. Dan Engelman from Boston is the guy that made this comment talking about the turnkey order set to prevent acute kidney injury after cardiac surgery. And he is the driver of ERAS in North America, ERAS cardio in North America. And so this is a busy slide, but it's looking at all. On the left, you've got the STS guidelines. In the middle, you've got the ADQI consensus. And then you've got ERAS cardiac guidelines. And then you've got the ERAS cardiac consensus on the right. So they put all of those together. So they say perform a kidney health assessment. So in other words, be sure of how the kidneys are functioning prior to surgery. If there's a problem, investigate it before surgery. If you have the opportunity and the patient's not unstable, which might include a renal consult, acid-base status, and even renal ultrasound to see if in fact there's problems with the patient's kidneys that will become manifest after surgery. If they manifest after surgery, you're playing catch-up. And we know that once a patient goes on to dialysis, the mortality increases from 1 to 20%. So, and it's because of a variety of, not the kidneys themselves, the patients get stuck in bed, they're getting multiple catheters put in all kinds of unfavorable parts of their body, which predisposes them to sepsis and thrombus formation and catastrophic events like pulmonary emboli. Discontinue your ACE inhibitors and your ARBs. That is accepted in the consensus on the right. Preserve adequate intravascular volume in the setting of dynamic fluid shifts and cardiopulmonary compromise. So you get sick patients and they do not behave well after surgery. So you've got to monitor your fluid status, and invasive monitoring has been shown to be beneficial in those patients. Restrict the use of excessive ultrafiltration and hemoconcentration during bypass. That's important that you tell the perfusionist not to take off too much volume. Intraoperative and perioperative individualized goal-directed therapy to reduce the incidence of acute kidney injury, avoid hypothermia, goal-directed oxygen delivery, optimize intraoperative glycemic control. I think all of these things we know. And intraoperative blood salvage to maintain the hematocrit above a prescribed threshold value. Avoid transfusion if you possibly can. And then postoperatively, avoid prophylactic use of diuretic therapy. Just giving Lasix in the postoperative period in a patient with normal renal function and normal cardiac output without other risk factors has been shown to be potentially injurious. So just giving Lasix 20 milligrams or 40 milligrams, what have you, is not good for the patient. You need to decide by seeing the patient and checking your monitoring. And you look at the KDIGO stage 2 and 3 CSA-AKI long-term follow-ups, perform multidisciplinary review all the time, especially in the dialysis-dependent patient. That's really important. The nephrologist doesn't just come in and do his thing and leave. That's not how you're supposed to look after these patients. It has to be a multidisciplinary. And the surgeon does remain relevant, okay? Because the only person that knows what really happened in the operating theater is the surgeon and the anesthetist that was there at the time. So the role of the surgeon in overseeing this together with your colleagues is multidisciplinary. This is not a dictatorship. Everybody's got an input. And then optimize glycemic control. The use of low tidal volume ventilation, less than 10 mils per kilo, that didn't appear on the criteria, but it probably does. If the patient's hemodynamically stable and his lungs aren't wet, he can probably tolerate that. This is again a very, very busy slide, but I just want to look at the pre-op. You do the health assessment, perform the analysis, consult nephrology, optimize glycemic control, hold the ACEs and the ARBs for 48 hours. I must emphasize this, because the minute you put the patient on bypass, you drop the systemic vascular resistance, they then get vasoplegic, and people start saying the patient's septic and he's in cardiogenic shock. It's not. The doctors have made a mess. Okay, so the doctors have to be aware of this, that when you're seeing a patient, either as the anesthetist or the surgeon, you must stop those things for 48 hours, because it does translate into problems postoperatively, and it messes the kidneys up. Limit aminoglycoside antibiotics and use vancomycin judiciously, and give clear fluids until 2 hours before. And I hope that we're doing that with our patients now. It does seem to be beneficial. Most of the other things we've been over a few times, the intraoperative ones, oxygen delivery, maintaining the temperature, optimize glycemic control, avoid non-steroidal, limit aminoglycoside, use lactated ringers as the preferred fluid for bolus intervention. Everybody likes colloids. They're expensive, and they move into the third space, and they take longer to mobilize. So generally we should be using lactated ringers. And also it's cheap, really cheap. So, compared to Gellifusion and all this other stuff we use. Monitor hourly urine output with a single lumen indwelling catheter, and then optimize intravascular blood volume using invasive or non-invasive functional hemodynamic hourly monitoring. Fluid challenges with lactated ringers if the patient's oliguric and the cardiac index is less than 2. The CVP is less than 5. Pulmonary artery diastolic less than 14, or SVV greater than 13. Now we can measure all of those things. So take the guesswork out of cardiac surgery, and diuretics if the CVP is more than 15 and the pulmonary artery diastolic is more than 20, and consider ultrafiltration if diuretic unresponsive. And then implement goal-directed hemodynamic therapy in oliguric, high kidney injury, positive biomarker patients. We're not using NephroCheck here as far as I know, but we should start thinking about it if it's available. Use fluids, diuretics, and inotrope. Systolic blood pressure of 100 to 130 and a mean arterial pressure of 65 to 90. Cardiac index of 2.2. Urine output of 0.5 mils per kilo, and if we're measuring mixed venous oxygen, must be more than 55%. And you do daily creatinine monitoring, urine output hourly, until there are no further indicators of cardiac surgery-associated acute kidney injury. Limit transfusion to a hemoglobin of less than 7 or less than 8 in the presence of oliguria, lactic acidosis, low cardiac output, or positive urinary biomarkers. And for persistent oliguria and a creatinine rise of more than 30 mics, adjust medication dosing interval for renal function as per institutional policy. There's a lot on this slide, but it covers everything that we should standardize in the care of cardiac surgical patients. Thank you. Have I overwhelmed you with information? But I think it's very succinct and very clear.
I wanted to ask you a question. In that last slide, they said the indications for diuretics, they said we should look at the pulmonary artery diastolic. So we obviously don't have that without SCOMGAT. But as an alternative for us, could we not use that Vigileo algorithm on the cardiac output monitor that says SVI over 50, give a diuretic?
Well, they include CVP and SVV.
They said it's CVP above 15 and then that.
Yeah.
So I just wondered if we could use our cardiac output monitoring instead.
Well, I'm not sure. I mean, they didn't include it in their. This is a literature review of 335 papers.
Yeah.
So this is how they arrived at this consensus. So I think we can measure all those things that exist on that consensus paper. So I don't know about that. You'd need to investigate it and find out.
James, I believe that we use more and more invasive monitoring now, but what's your thought in terms of increasing support to, say for example, you increase in vasopressin or noradrenaline to such an extent that's high level to maintain mean pressure of 65, but isn't that inotropic, high dose of inotropic support is also a contributing factor to the acute kidney injury, although you maintain a high pressure?
Yeah, it is, but kidneys die if you don't perfuse them. So if there's no perfusion to the kidney, it's going to shut down whether you use vasopressin or not. And those patients are outliers on the extreme.
Yeah.
And there's reasons for them needing inotropes.
Yeah.
Either they're vasoplegic and septic, and that's the importance of stopping those ARBs. I've had to educate everybody about ARBs and ACE inhibitors. Because patient goes on to bypass and they're on inotrope for 3 extra days because of that. But if you're needing high dose vasoconstrictor and you're needing high dose inotropes and the cardiac function is the problem and you're getting lactic acidosis, that's because you're not perfusing anything because the pressure's low. So what you're trying to do is keep a perfusion pressure up. But that's just a number. And that's where, if you really want to get into it, if it's a low cardiac output patient, that's when you need to talk about other support for the patient. Yeah. And I'm sure we've all seen it with ECMO patients. When you put them on ECMO, they start passing urine.
Sure. Yeah.
Because you take away the constrictor and you give them perfusion pressure. Yeah. So those are the outliers. They're on the edge.
James, I just want to ask your opinion on something. So I had a patient recently who Creat was 115 pre-op. Metabolic syndrome, came in for a bypass. Urine output, everything else pre-op was fine, but his creat was 115. On induction of anesthetic, the patient's blood pressure was extremely low. His mean arterial pressure was in the 40s. But he was producing CO2, and so I had quite a long discussion with the anesthetist saying, I think this is too low. So he said, no, it's fine. He's on anesthetic, and he's got CO2, and he's perfusing, and that, it's fine. Proceeded to do the bypass. Patient then doubled his creat immediately the next day. The bypass perfusion pressure, we made sure that it was perfused high. Because of that, I spoke to the perfusionist. I was like, listen, I think we should perfuse this patient at higher pressure. So there was nothing, the op was completely straightforward. Doubled his creat day 1. Became anuric, lost his urine output, had an AKI, and he's never recovered. Now it's months later, his creat is about 500. He's heading towards, I spoke to the physician, he's heading towards dialysis, permanent. And this is from somebody who didn't have anything. I mean, but he did have a 115 creat. So I just want to ask, first of all, do you think that induction period before, that AKI, am I being, because in my mind, that's what caused it, but I may be completely wrong. So I just want to hear what do you think could have possibly contributed?
Yeah. Look, the absolute number, what was the GFR? So the number is...
Yeah, his GFR was below 60.
So already if you look at the criteria there, he was probably somewhere around stage 2 anyway. So it probably meant that, in order for your creatinine to go up, you need to have lost at least 50% of your renal function, if not more. So he probably had maybe 35% renal function. And he's probably hypertensive. He had lots of stuff going on in the background. And Bruce and I have had a recent experience with a patient that the chap that we abandoned the operation. I mean, he went into renal failure just from induction of anesthesia, and he didn't drop his blood pressure, and he had a balloon pump. So, you need to unmask that. So if someone's got a creatinine of 115, they should have a renal consult. You're going to say, what should you do the next time? It could almost certainly be from the induction of anesthesia, because if he lost a few nephrons, it was enough to put him into chronic renal failure, or as I said, dialysis dependent. So what we should be doing with all of those patients, when we see that creatinine, they should have a renal ultrasound and nephrology consult, and you should look for urinary biomarkers, because they've had contrast. And although the contrast we give now is less injurious, what was the time from his angiogram till his bypass?
It was a main step.
Yeah, so the contrast-induced nephropathy is still real, plus you had hypotension, and you probably had pre-existing renal disease. So and the anaesthetists need to be more vigilant. When we see a guy like this and we've got the time, we need to do the right thing according to these guidelines. And I think that's the purpose of these guidelines. So we can then avoid those kinds of scenarios, or at least mitigate them. So, yeah.
I think the next time, in this guy's situation, because it was a main step, we put a balloon pump and took him to theater, so the contrast definitely.
And the balloon pump, all the microemboli. So there's multiple reasons, probably the same thing that happened with our patient, Bruce. It was multiple different things. It was a balloon pump, he was 81, he had a calcified aorta. So, his creatinine was, I think, 108. And we didn't even put him on bypass. So just that short period of the balloon pump, because we took it out the next day, plus hypotension, probably, plus contrast, probably catastrophic, yeah.
Are we doing the clear fluid thing pre-op?
We're trying to do it, Bruce.
Yeah.
We're doing it.
Mediclinic.
Yeah.
Is it just the carbohydrate drink?
Yeah.
Yeah.
Or is it clear fluid? Patient can drink water throughout.
So I'm not sure exactly. Need to maybe standardize it.
Okay.
So,
Yeah, most of the patients are sleeping at night, so they get woken for their drink in the morning. But I don't think most.
I'm just wondering, is they're already like predisposed now?
Yeah.
Okay, yeah.
Well, those
Hydrating
you say
and
that
hydrating.
those patients, what you should have with them is a proper nephrology workup, I think,
Yeah.
if you want to avoid these things.
Yeah. I think it'll be, I think that for me the takeaway is, even if it's an emergency, if it's a main stem, get the nephrologist involved before, because in this case, call the nephrologist after, we just kept chasing after.
Yeah. All right. Any more questions? Well, that.
You want to watch online people, whether they
Are
got
there,
questions.
the online people, any questions? Where are they?
There are no questions. Okay.
I think if we can do this, it'll be better for our patients. And as long as everybody's aware of why we're doing it, I think it's the most important thing. They need to be aware of why we do it.
And James, before we end, it's such a great idea. So should we start implementing these guidelines incorporate into our ICU, especially post-operatively, and then the busy slide, the last slide will pre-op, that we'll take away intra-op and post-op, kind of like put up guidelines to educate our critical care nurses looking after our patient, and say, you know what, this is the algorithm, and
Well, I think
we should do that.
Well, we're planning to do ERAS.
yeah. So it's going to be all part of
JJ
it.
all part of
practice. So it will all come into it.
Yeah.
Sure.
We're hoping to launch ERAS formally for all the patients from May, but to educate everyone before that, so that everyone knows what to expect.
Yeah.
But it's a lot of the stuff like you said, we do a lot of it anyway, but just to get it nicely 100% compliant.
Yeah.
From May.
Yeah, and I mean, I always keep referring to the fact that I'm old, you see. When I started cardiac surgery, we didn't do a lot of this stuff. We did a lot of thumb suck. We gave colloid, like bucket loads of colloid. We gave mannitol, and then we spent 3, 4, 5 hours giving them fluid in the top because they were peeing out the bottom, and everyone had to have renal dose dopamine. Renal dose dopamine. And it's nonsense, So stuff that was this almost cast in stone has been found now on evidence base to be nonsense. Oh, just the one thing I wanted to mention about the phenoldiprem. Dan Engelman is not keen on phenoldiprem. He doesn't think that the evidence is strong enough to justify its use. And what he did say, they have a lot of hypotension. It's a calcium channel blocker. So they had a lot of hypotension in their experience. So at the moment, it's not in his those last sets of guidelines. So don't go ask for phenoldiprem, 20,000 Rand an ampule probably, because it doesn't seem to help. And these are probably going to change, as we know. Urinary biomarkers are very big now, so we need to find out. There is a standard cohort of renal biomarkers that we can get that will help determine acute kidney injury in the post-operative period.
Also, just wanted to quickly ask, because there's a lot of stakeholders in the room, it's actually a good opportunity. I think it sort of overlaps also into what question you were asking about inotropes and the dosage. How do we get to change our region to administering inotropes in a dose instead of this vague milliliter?
Well, I was listening to one of the intensivists talking yesterday about a patient being on 60 mils, and that's the maximum dose. And, if you're 35 kilograms, 60 mils, I don't know what it is, and if you're 80 kilograms or 100 kilograms, I don't know what that is. The sort of inflection point for intervention for mechanical support in patients with low cardiac output, we're talking about cardiac patients now, is when your noradrenaline reaches 0.4 mics per kilo per minute and your adrenaline reaches 0.4 mics per kilo per minute, plus minus other stuff. But when you get to that level, you probably should be thinking about, does the patient need either a heart transplant, LVAD, or ECMO? Because patients do not survive for any length of time. If you put them, I've asked everybody, how many patients have you seen survive who've been on 40 mils and 40 mils? They all die because that kills the kidneys, causes splanchnic ischemia. And so what you're doing is getting a nice pressure, but the patient is slowly being constricted to death. So we need to realize 0.4 mics is the maximum dose of adrenaline and 0.0 per kilo per minute, and the same with noradrenaline. So, and when you start adding all the other drugs like vasopressin and so on, you're looking at a very, very poor prognosis, and should we be looking at mechanical intervention? So that's why I keep saying doses are important. Mils don't tell me anything. And for cardiac patients, maybe for septic shock you can do 50 mils and 100 mils. Cardiac patients, it's dose specific. And if you look at any literature, it's not mils, it's mics per kilo per minute. All drugs.
If we could laminate we have it in theatre based on the patient's weight, horsepower, and it gives you a conversion split table.
Yeah.
And it's principally weight,
Yeah.
5 kilo increments. If we could laminate.
Would you want to use it just as a reference, like, so that you
look
can
at
say,
bedside, and that'll help change the mindset.
I think
can we not just change the pump to dose, because it gives you dose and the mil underneath,
Yeah.
so you won't be lost if you used to mils, that will still be on the front,
Yeah.
but your dose will be visible to everyone. You don't have to reference to anything on the pump, as
Yeah.
all these pumps are designed
To give you the
with
dose.
that
Yeah.
function, like that.
Yeah, I think we should do both.
Yeah, I second that.
I think Renee's question is very important, because a lot of times they're just telling you moles, and then it all depends. You can put 1 milligram in 200 mils, 1 milligram of adrenaline in 200 mils, and then you're running at 30. It's different when you put 8 milligram in 200 mils. So I think the other mindset change in ICU, that's important. We have to tell our nurses that, please tell me how many mics
Yeah.
that the patient is on.
There's a lot of pressure now for the
Yeah.
nurse to do the maths or look at the paper, but if it's on the pump already, nobody has to struggle to work anything out. It's there.
Yeah, no, last time I
It's just
asked, they
when
had
you
to go and
start
do a
the-
calculation. I said, but that's not okay.
I have a suggestion. I think because we do most, our patients, I think it's our prerogative as doctors. I mean, I trained in minds. Like coming here was a mind shift. I mean, even Hillcrest and all of that, not just Narrative. But it's just a regional thing. But I think if we're all in agreement that it's better for the patient, that's all that matters. It doesn't matter about
Yeah.
what we feel.
Yeah.
If it's better for the patient, it should become policy from our practice that our patients will do. Then it's our responsibility. If the nursing staff not sure or uncertain and stuff, we must take it upon ourselves to teach, to help, to explain.
Yeah.
It shouldn't be scary and stuff, but if it's better for our patient, just my personal feeling is, I'll start today. Certainly, I'm doing stuff now in Hillcrest and so that will start immediately. Because I can back it up. I mean, I can say, listen, it's better for the patient. Who doesn't want it? And I think we shouldn't tiptoe around these things. We should just do it. That's just my suggestion.
I'm sure, because the teaching that's needed is just that minute or two of when you initiate the inotrope to program the pump.
Yeah.
It doesn't, maybe the first time it will take a few minutes, but as you get used to it, you get so slick, it's another minute of your time, and then you've constantly got a dose available
100%.
on the screen. So maybe we can liaise with the reps of the pumps, and I don't mind helping, and any of the, anyone that knows can teach the next person.
Yeah, someone has to teach
How about
me
we get an
because I also
incentive?
don't.
Okay.
Give us an incentive
Yeah.
training, because I feel like what Dr. Fulton said, we are all just calculating because we are so not used to too much noise. Instead, we are so used to noise per kg, per hour. And if we can just get them in service, like all the RNs that are nursing cardiac patients, can they just get that in service straight? Then we have a lecture statement to say, but you were taught it. You still saying you don't know.
Okay.
We are finding it very difficult, I must say. It's not only one person, it's almost everybody. We all come together and we're like, where do we start?
And the value of it is, I mean, the value of it is it allows you to be goal directed. When do you add a second inotrope? When do you say the patient's in serious trouble? You don't want to wait until his patient's on some arbitrary number and then you say, okay, that's a lot. You know,
It's not science.
if it's 0.4, I mean, Martin's thing was when the patient was on more than 0.2 mics of adrenaline, the patient was in serious trouble. You got to start thinking about what are you going to do next. So 0.4 is the max. If you go to look, everybody knows, look at the literature, 0.4 mics per kilo, it ceases to be effective. That's why 40 and 60 just give you a number, but it does not improve outcomes. So when you get to the point that the inotrope dose is getting 0.3 and going up, the time to intervene is before you get to the maximum dose. In a young patient who's had an MI or cardiogenic shock, you're waiting. A number of times I've been asked to see ECMO patients 48 and 72 hours later. It's too late. The prognosis is 0. So, you know, that's why when the inotropes are going up, that's the time that you need to look at the patient and you need to have the dose standardized so that you can intervene before they reach the point that their kidneys have shut down. So that's the value of it, is knowing how much you are giving. You know it, you can say it's a lot, but how much is a lot? 0.4 is max. So you want to know when they're at 0.2 and 0.3 and 0.35, not when they're at some number that's kind of meaningless. And I think if you look at all the ERAS guidelines, it's all numbers based. You can measure stuff and you can intervene accordingly. That's why you measure, so you can intervene. Okay. All right. Call it quits.
Say bye to the people.
Hi.
You have to close, yeah.
Oh, yeah, I thought you were going to close.
Oh, am I going to close?
Yeah.
Okay. Thank you for all the online attendees and then the people present here. And first of all, I would like to, for this 2023, I'd like to wish everybody well. And I also would like to introduce our academic coordinator, and that's Renee, and she will be coordinating all our academic program, including introduction of ERAS protocol in beginning of May, and this program will be run throughout 4 or 5 hospitals that's doing cardiac surgery. And obviously you will see Renee more and more often because she's also in charge of our nursing critical care program, and that will be launched every Friday, every second Friday in a month. So if you have any issues, or you can contact us by her, then she'll be our general manager, administrator, ///. So that's it, and hopefully to see you guys soon again. Thank you.